Welcome, everybody, to this second episode of the 2026 webinar series of the European Society of Human Genetics. My name is Martina Cornell, and I'm the president of ESHG. You will remember that in episode 1, we already started speaking about genomic newborn screening, and today we'll continue with that topic. And we today have 3 speakers. First, Amanda Pichini from the Generation study in the UK, where they are screening 100,000 babies on more than 200 conditions. And then we'll hear from Jim Bonham, the president of the ISNS, the International Society of Newborn Screening, from the perspective of traditional newborn screening. And then we'll move to Gulcin from EURORDIS, who will speak about the challenges of genomics newborn screening from the perspective of patient organizations. And then we'll have time for some Q&A. If you have any questions already during the presentations, you can type them in the Q&A. But we'll first have the 3 speakers present. And unlike earlier presentations, we now can move on to 17:10. So we have 10 more minutes as compared to the previous webinars. So we really have some time to talk about everything that has been presented. But for now, I'm handing over to Amanda Pichini. Thank you very much for accepting our invitation.
Thank you very much for inviting me to present. It's really great to have the opportunity to share with you all in the virtual room about how we've thought through the process of designing the Generation study and where we're at in terms of delivering the study, as we're now at a stage where we're almost halfway through the recruitment of the 100,000 participants that we're targeting. And that means that we have some data that's starting to emerge. So hopefully I can touch on that as well and lead into my colleagues who will then be able to talk about and add to some of those perspectives from their experience as well. So here we go. My slides should be sharing now. So just as a brief introduction, my name is Amanda. I'm the clinical director at Genomics England, and I'm a genetic counselor by background, registered in Canada and in the UK. Now, to start just by giving some context, because I'm conscious many of you as listeners will be coming from a range of different sort of European or other countries. Our context in England is, in terms of population-wise, we have a population of 57 million people, the majority of the population in the UK, which sees around 600,000 births per year. We operate in a national publicly funded healthcare system that we refer to as the NHS, which includes extensive clinical genomic testing that's already happening for a range of other indications, largely diagnostic indications like for rare diseases and cancers. And that includes things like single gene panel and whole genome sequencing. We also have a newborn blood spot screen, which is offered to every baby around day 5 of life. This is an opt-in decision that parents make, although it is debatable the extent to which parents recall the conversation that they have about agreeing to have this done for their child, but it is a consent rather than a mandated or opt-out system. And currently the blood spot screen recommends testing for 10 conditions, including sickle cell, cystic fibrosis, congenital hypothyroidism, and some metabolic conditions, as well as an additional 2 conditions, severe combined immune deficiency that's under an evaluation and in preparation for a potential evaluation of spinal muscular atrophy. In terms of Genomics England, the company that I'm here representing, we are a company that is solely owned by our Department of Health and Social Care. So we operate very much like a government body. But we are very much there to sort of support our national health system, as well as work with researchers in terms of the large national database that we house that includes genome sequences and linked de-identified clinical data from already over 100,000 participants from previous work that we've done doing genome sequencing in a diagnostic context for patients with rare diseases and cancers. Our overall vision is a world where everyone can benefit from genomic healthcare. And so we try and really operate on both sides of the system, both the clinical side, providing diagnostic whole genome sequencing, and also on the research side, making that data available to researchers to hopefully stimulate further discoveries and diagnoses, developing treatments for the future. So really the Generation study aims to sort of fit into this clinical and research kind of model that we have, but it's new for us to sort of look at the genome in a context of newborn screening. So as many of us will be aware, I won't sort of labor these points too much. I think this was also covered in the previous webinar, but just sort of highlighting some of the challenges that we all experience in sort of undertaking research programs to generate evidence around genomic newborn screening. And actually, I think this isn't exclusive to genomic newborn screening either. These are questions that apply across any kind of new screening program, regardless of the technology. But we have to think, for example, about optimal approaches to consent. Again, how we're layering that on top of the existing consent approaches to screening in those countries, which can range from opt-in, opt-out, mandated, range of other approaches. How do we make sure that if we're doing that in a way that balances sort of informed choice, the child's growing autonomy over time, maximizing our ability to find cases for the benefit of those children where those real and treatable cases are relevant for them. We think about questions around equity, how we make sure that the research studies we design and ultimately any future programs can be delivered equitably across diverse populations. That includes diversity in terms of urban, rural, different ancestral groups, different other sort of community, familial, and individual factors that we have to take into consideration, which can be particularly difficult when we're trying to develop things at a policy level and things that are going to work at a population level. We have to think about how we return and communicate results. That includes not just how we determine the right criteria for choosing which conditions and variants to look for. I'll share a little bit about our process for that. But also when we have those results, how we communicate them and how we provide the right wraparound support to make sure that families, whether the result ends up being true positive, false negative, that we're providing the support that's needed in those situations. And then we're always working in the context of some kind of healthcare system. So we need to think about workforce readiness. And in our context, in the publicly funded system we have, how we can equip the workforce to deliver change if we were to implement genomic newborn screening, whilst being mindful of the fact that for many healthcare professions, genomics is relatively new and not something that they are familiar with and using in their day-to-day practice, although that's changing and becoming more commonplace. And also without disrupting standard care and what are often very resource-strained services. And especially when you're introducing new change, even if you hope that at the end of that, it will make things easier in the longer term, there's often at least an uplift in terms of implementation that needs to be considered. So the scope of our research studies, the generation study, is to sequence the genomes of up to 100,000 newborns in the UK over a approximately 2-year period going into the end of March 2027. As a research study, we've had to get research ethics approval to run the study, but we're running it very much in partnership with our health service, and it is distinct from our existing sort of public health well-established blood spot program. Importantly, this isn't just a study looking at genomic newborn screening. It is broader than that. So we spread that across 3 aims. The first aim, which I will talk mostly about today, is where we're wanting to evaluate the utility and feasibility of screening newborns for a larger number of conditions using genome sequencing as a technology. But parents are also agreeing for that data to be available in the longer term. As I mentioned earlier, one of the key functions we have at Genomics England is making that de-identified data available to stimulate research. And so those parents are also providing consent that their baby's genome and linked health data can be used, one, to help us evaluate those screening questions, which often take a longitudinal sort of number of years to help us understand the value of that, but also for wider discovery research within our acceptable uses policy, making sure that it's linked to research that can contribute to furthering our knowledge of genomics and health, developing new treatments and diagnostics. And also because that data is being held in the long term, to explore the potential risks, benefits, and implications of storing a baby's genome over their lifetime. That means we might be thinking about asking different questions of the genome over time. Our current question is looking for childhood onset treatable conditions. But with that genome sequence, we may at a future point in time be able to ask for later childhood onset conditions or adult onset conditions as participants get older, or about pharmacogenomic findings. We've not at this point committed to doing any of those analyses, but these are the types of use cases that we want to explore and have ongoing dialogue with the public in terms of the societal view and also with our participants to help us understand what the potential of that could be. So underpinning a lot of this has been sort of a real commitment that we've had to co-design and really bring in the perspectives of public participants and patients throughout. And I'm sure Gulcin will also speak to this to some extent in terms of how we can really make sure that the voices of patient organizations are represented in work and translational research like this. But before we started even designing the study, we started with a national public dialogue that was aimed at members of the public to deliberate on whether we should even ask the research question about looking at genome sequencing in newborns, and what are some of the risks and caveats that we need to consider in setting that up. How can we make sure we put our best foot forward in presenting and running a study that gave us the best chance of generating evidence that could help inform future decision making about whether genome sequencing could form part of screening in the future. We also involve public dialogue in the principles we establish for how we choose conditions, which I'll talk about more shortly. More specific pieces of work, for example, dialogue with ethnic minority community leaders that are more prevalent in the UK in terms of how we might need to think about communicating this research study to people in different communities. What are some of the considerations we needed to think about, how we can make sure we're reaching people in different communities equitably, giving them an equal opportunity to make at least a decision one way or the other if they wanted to take part in the study. And also kind of working on more in a co-design way, we have a team of user researchers which operate effectively like very rapid qualitative and quantitative research methods that help us to really keep our finger on the pulse of what our participants and other key stakeholders are thinking as we develop and design the study. So for example, over the course of various rounds, we've worked with over 150 parents that we've used to help test key messages about the study. Are we getting the balance right in terms of risks and harms and how we communicate consent to help parents make an informed decision? How do we frame that and the content and materials we have? With midwives and research staff helping us to understand what the current maternity pathways and birth pathways look like, so we can think about the right times to introduce a study like this and the right kind of staffing models that we would need. With other specialist healthcare professionals in terms of returning results, and also with patient organizations. So we really wanted to make sure that we were incorporating the views of patient organizations and people that had experience of a rare condition coming from that perspective, and members of the public or people that have had experience having a newborn screen result, because often their perspectives can be somewhat different. They're coming through in a different journey than potentially having experienced a diagnostic odyssey. And when we're thinking about population screening, we need to think about all of those angles and perspectives. This is you'll see QR codes in a few of my slides and links. That's really just to help link you to more detailed information beyond what I know we'll be able to cover in the sort of time we have today. The other key thing that's helpful to point out about our UK context is how we have tried to maximize existing infrastructure. So I mentioned earlier on, we already do a lot of genetic testing in the UK, including whole genome sequencing for certain diagnostic indications. And a lot of that is delivered through regional structures, genomic medicine services that include the laboratories that do the testing and interpretation, and the alliances around them, which provide clinical leadership that are helping to develop and embed genomic testing into different pathways. So we've leveraged the expertise that they've already tried to do with diagnostic testing to help support delivery of the generation study as well. So that infrastructure and those clinical and lab experts have helped us to develop and map the treatment and support pathways, so we know which specialist teams we would need to refer different condition suspected results to. That's the organizations through which we've provided additional funding to enable more timely access to genetic counseling in the period after a result is provided. It's where they've sort of used a lot of our training tools to raise awareness and engagement with different healthcare professional groups, from midwives to pediatricians and primary care professionals, and also to kind of support comms, help to enable equitable recruitment through more community engagement as well. Through that work, for example, and all the mapping we've done for the different conditions and specialties across those 7 regions, that's allowed us to engage over 400 different clinical teams across the country that are in some way primed to be ready to receive a result from the study. A good proportion of them may never get one of those results, but the aim is that we're really trying to think more sustainably about the future in priming the healthcare workforce to think about what this could mean. I'm just going to spend a little bit of time, not much, on how our kind of recruitment journey works and how we work with staff on that. The user research and the engagement we did with parents and healthcare professionals has helped us design our journey, where parents are approached in pregnancy, usually midway through pregnancy. They might be actively approached by a member of the study team, where study funding is generated to appoint staff that are helping to make sure that parents are made aware of the study and have those sort of follow-up consent conversations at the right time. Or parents might also become aware of the study passively, meaning they might see a poster, they might see something in the media, they might be directed or find their way to our website and be able to register their interest that can be picked up by a member of the study team. And what we found across that experience and the number of sites that have been open so far is that there is a range of kind of best practice models that we're learning have been really effective. And that includes really trying to maximize passive awareness, looking at places where mums and parents go to surface the generation study that might generate interest, and then focusing efforts in teams on parents who may need a more one-to-one, sort of more time to sort of talk through the study and answer questions. Potentially some might need interpreters, for example, that might take longer time, and giving more time for those direct approaches. What we also find is really crucial is there's the point at which parents consent, which is usually before the birth happens. And then as the birth happens, our primary sample, which is cord blood, needs to be taken very shortly after birth. And that relies on not just the research team, but the wider delivery suite and maternity services being aware when a parent is taking part in the generation study, so they don't miss that cord blood sample being taken. And there's a lot of operational complexity involved in that we've had to kind of optimize over the course of the study and gaining experience in what that looks like. So really having buy-in, not just from the research team, but the wider clinical team, who we know are very resource stretched, but if we try and limit them to sort of general awareness, understanding the importance of the study and helping to make sure that a sample can be taken, then that can really help make sure that this process works as smoothly as possible. So really having drivers at a senior level in those hospitals and people really making it work on the ground is really crucial. We also, as I mentioned, worked with parents and healthcare professionals to devise the consent materials that we have in information sheets and on our website. These are also translated in about 17 different languages that are the most commonly non-English spoken languages across the sites that we run in. We've also worked very hard to think about readability. The reading level of our information sheet, for example, is around age 12, which we recognize we could do better. We had a real challenge with a lot of the genomic jargon that we had that we really worked hard to define. But that's a lot simpler, I think, than the average kind of participant information sheet that we might see for research studies. We've worked really hard on that. One of the particular things I wanted to highlight here is these keep in mind scenarios that you can see on the right hand of the slide, which is where we really try to emphasize some of the more complex aspects of taking part in a study like this. This keep in mind scenario is reflecting what might happen when a false positive result is received. Even though for any one parent that's going to be unlikely, we want to make sure that they're really thinking through the potential reality that that could happen to them, so that they're comfortable with that possibility and understand that potential risk before making a decision to join the study. And it's something that we've heard is very valuable from site staff that they use in helping make sure that parents are really thinking through the decision to join. I also mentioned that kind of the workforce readiness is a key aspect of thinking also about what could happen in the future if we were to incorporate genomic testing more in newborn screening. So that's something we've also paid a lot of attention to, trying to focus this on the competencies that would underpin what different healthcare professional groups would need to know and do to be prepared to deliver certain aspects of the study. Two examples I'll call out here. One on the bottom right is a resource called Genotes. So this is an existing resource that already was in place to help provide just-in-time information about genetics and genetic testing to clinicians who may be not as familiar with genetics in their day-to-day practice. So we worked with that team who are already trying to make this resource broadly aware to a range of healthcare professionals and develop some just-in-time information about the generation study, focusing on particular aspects like communicating a result so that as and when that goes to a particular clinical team, they have access to that just-in-time information that is quick and easy to read and can help prepare them in the moment, as often advanced training only goes so far to help prepare the workforce when they're dealing with lots of other things in their day-to-day job. We also, this debating what to do square is an example of what we call informed choice cards. These are based on realistic scenarios that have come from some of the parent interviews that we've had. that we're trying to surface to the healthcare professionals that are having consent conversations with families. They include some potentially trickier situations, like maybe parents disagree, or they have concerns about the invasiveness of the sample being taken, or about the uncertainty around results. And really, they're there to kind of generate that discussion as we train teams to think about how they would address some of those scenarios, how to signpost to information, defer to experts when needed, and helping to sort of emphasize some of those key messages, like the fact that this is a research study, it's not replacing standard care, it's not replacing the existing blood spot test. Oh, there we go, sorry. So in terms of where we're at now, this is just a high-level snapshot of numbers. I mentioned we're almost at the halfway point in terms of participants recruited. Since actually I wrote that slide, we're now just over 45,000, and that's across 75 different hospital sites in England, which we chose based on a range of factors: urban, rural settings, large, small hospitals, research active and not so active hospitals, because we really wanted an ability to see how this kind of approach works in a range of different environments across the country. And as I mentioned, parents are consented during pregnancy. That core sample, the primary sample we take, is cord blood, and that's what we see being taken in the majority of cases. Where cord blood is missed or can't be taken, there is the option for a secondary sample as a heel prick. And we're tracking at around 2.3% of samples failing for various reasons. That's still below our kind of threshold of what we sort of broadly expect if samples were to fail at the extraction or sequencing or other stages. So that's remained fairly low. We're keeping up fairly well in terms of processing those samples and going through to results. Our average turnaround time at the moment from sample to result is 17 days. The fastest result so far that we've turned around to get to a condition suspected result, in that case, that was a spinal muscular atrophy case, was only 8 days. Everything aligned very well in that particular case. For other cases, that's taken longer than 17 days. Our overall target in the study is to consistently be returning results within 14 days. So that's something that we're actively working towards. In terms of then genomes analyzed, I'll talk a bit more about how we got to that list of 462 genes associated with just over 200 conditions. But we see that then about 3.6% of all of the cases have one or more variants that have a signal to review. We then have a crucial manual review step where there's a drop-off in cases that ultimately we report to the NHS. Only 0.4% of the cases that we're seeing have one of those 200 conditions that we suspect that then go back to the NHS for confirmatory testing and care. And I'll break that down in a little bit more. So in terms of our approach to choosing conditions, as I mentioned, we're running this as a research study. We're very mindful that criteria already exist in our national screening committee, as well as other countries, for choosing conditions to screen. We felt we could take a slightly broader approach given we were running this as a research study, so we wanted to be able to learn from our experience, but still wanted to focus on early childhood onset conditions that could be actionable in some way. So we took a multi-step approach to doing this. We started by developing principles. We wanted a fairly small set of guiding principles that can put some guardrails around the types of rare conditions we would look for. We used some consensus methodologies here, working with members of the public, health professionals, and rare disease communities to feed into developing these 4 principles that you can see on the left of the slide. Broadly, our principles say that we want to make sure that there is good evidence of an association between variants in that gene and causing the condition that we expect it to cause. That, to the best of our knowledge, a high proportion of individuals with variants in that gene will go on to develop that condition, and where we expect there to be a debilitating impact on quality of life if that were diagnosed. Principle C, again, to the best of our knowledge, that there is an earlier pre-symptomatic intervention for the condition that leads to improved outcomes. I say best of our knowledge because, again, with rare conditions, we often run into the problem of sample sizes being very low and the potential for long-term history data to be collected also being very difficult to gather in a short space of time. So we're limited in the data that we have, but again, that's also why it's crucial that we're running this as research so we can see what that looks like if we're managing those results carefully. We also chose the word intervention very specifically because we didn't want to suggest that it could only be a gene therapy or a specific diet or drug that was viable as a treatment. There are other examples such as retinoblastoma, where access to early screening to identify hereditary retinoblastoma early is also considered an intervention. And Principle D is particularly relevant to our case in the NHS, where we want to make sure that that intervention is equitably accessible for all. So where there might be some conditions where there's a treatment under a clinical trial, where we couldn't guarantee access to everyone around the country or for a sustained period of time, we didn't include those conditions. We also worked very closely with the infrastructure of clinical governance groups that we have around the country, not just genetics, but also other pediatric specialties, making sure that there was capacity to test for some of these conditions, and applied these principles in a standard approach to over 1,000 different gene condition pairs. Ultimately, what filtered through that was, sorry, that should say 462, apologies, genes and 482 gene condition pairs that met our principles. We kind of group that as being associated with just over 200 conditions, as there are some conditions like severe combined immune deficiency, for example, where there are multiple genes that are kind of underlie that condition. We're also in the process of updating the conditions that we are testing for in the study. We'll still be at just over 200. We won't have surpassed sort of 300 conditions, but we are adding additional genes. Many are additional genes associated with conditions already on our list that we've been able to establish a good gene disease association, or other genes perhaps where a treatment has now become available. Also just wanted to quickly touch on some of the activities that fed into the process that we have in terms of returning results. We worked with different pediatric clinicians, as well as undertaking interviews with parents and children who, some of whom have a child with a rare condition, some of whom don't, and some of whom had their results come through the existing newborn screenings, reflecting on that experience. And the collection of that kind of culminated in some findings that have directed our approach to returning results, including we found that parents really value having initial contact, that first call, from someone who has expertise in managing that condition. So whilst in other research studies, we're conscious that different result models are used, for example, in some places, it's a central team of genetic counselors that are returning all the results. We, from what we had heard and from existing newborn screening practice, felt that the result was best given by the person, let's say the immunologist, who was going to be then carrying out the confirmatory tests and potentially bone marrow transplant for a child with SCID. What we wanted to emphasize, though, was that it wasn't just that clinician or that clinical team on their own. We needed to make sure there was multidisciplinary working, for example, having access to genetic counseling or referral to patient organizations in a timely way, and also that we were bringing primary and community care professionals like GPs and health visitors involved as early as possible. We also found that this helped inform the resources that we developed, just-in-time needs for information and support, that there needed to be just-in-time training for clinicians so they were clear on the next steps they were taking when they had a result. And of course, in general, that these principles are only so good as being general. We needed to make sure that there was still enough flexibility to treat each case on an individual basis, depending on the condition, the urgency, the individual and family needs that presented. So I mentioned some of the resources that we developed. There's two key ones that we developed on the back of that feedback that we had. One is a confirmatory test pathway that we've developed for each condition that had a unique confirmatory test. This provides some high-level guidance on the level of urgency needed for that initial review. The confirmatory testing, in most cases, there is a non-genomic confirmatory test that would need to be done after our result is issued to confirm the condition, and at a high level, what the management looked like and links to onward support. And then a more patient-facing or parent-facing resource, which was providing at a high level information about the condition that they will have just been told their child is suspected to have. It provides some very top-line information to help fill the gap between being told of a suspected condition and potentially that being confirmed, which can often be a really uncertain time for parents. So we wanted that to really help support what we call kind of informed Googling. Often we know parents' reactions might be, you hear about something, you want to look it up and potentially then see the worst case scenario. So the aim of this information sheet is to try and direct parents to some accurate information, including UK-based patient organizations that we've also provided some awareness and training to, so that they are potentially prepared for parents to contact them from the study and provide some support. And then just very briefly, in terms of how we carry out our analysis and interpretation, I think this is very crucial because often we talk about choosing conditions, but really it comes down to variant level decision-making to really make genomic newborn screening work appropriately. So we generally have our process broken down into 2 steps. The first is an automated pipeline that prioritizes variants that we think have a high chance of being pathogenic or likely pathogenic. These are drawing from existing databases like ClinVar. For a time, we were using a commercial data set as well through QIAGEN and also through our internal databases of variants that have been previously classified in that way. Also loss of function variants, where that's the mechanism of disease, and other filters to help maximize positive predictive value. That's where we get to the 3.8, 3.6% of cases where there's some prioritized variant to review. But that is an imperfect system to just use that automated pipeline alone. The information in our variant databases is imperfect. It might be that the combination of variants together doesn't really contribute to kind of early onset disease. There's a range of reasons why variants that are flagged may not actually be suitable to report. So the second step is manual review. And in the UK, we have the benefit of having a registered healthcare professional group called clinical genomic scientists. And they are experts in variant interpretation. They do this in a diagnostic setting. So we work with some of those scientists who apply variant classification criteria to these variants to make sure they meet our threshold for reporting. So being at least likely pathogenic, and as far as we know, not being just associated with hypomorphic or late onset disease. Often those lines aren't so clear cut, and applying variant classification criteria in a screening context can be challenging. So we also bring in multidisciplinary discussion with other clinical and lab experts to review evidence where required before reporting a case. And this is something we're starting to get a lot of learning from. That QR code also links to a publication we released last year, which gives more information about the rules that we've set in our pipeline. So overall, the end-to-end results journey, I only have maybe 3 minutes left, I don't have too many slides left, is our automated pipeline prioritizes cases. Those go through manual review. If they are found suitable to report, then a research report is issued with the referral pack that includes that confirmatory test pathway and information sheet. The appropriate specialist team is identified on a regional basis where confirmatory testing can then take place. The family is contacted, and we're able to then hopefully follow up in terms of the outcome, knowing if that was a true or a false positive case, and provide access to further support. This is just a snapshot of the results that we found so far. A third of the cases that we've seen align to conditions that are on the UK blood spot test, which is broadly what we expect because these tend to be more common of the rare conditions. We see that the majority of these are concordant with the result that's also in the blood spot, but some are discordant. And one example of this is congenital hypothyroidism, where we have found some cases with variants in a gene called DUOX2, which may be associated with a milder form of hypothyroidism that isn't then meeting the cutoff that's been established for thyroid hormone screening in the blood spot program. So that's something that we're looking at more closely. That may be a gene that isn't suitable for screening, or there are particular variants in that gene that aren't suitable for reporting back in this context. And then across the range of other conditions, we are seeing a vast range across different specialties. This makes up the remaining 2/3. A couple that I'll flag here, we've seen a few cases of osteogenesis imperfecta due to collagen 1, A1 or A2 genes. Interestingly, those are genes that are dominantly inherited, and they do exhibit some variable sort of penetrance and expressivity. That creates more of a challenge for reporting, and those have been some of our trickier cases in terms of following up. We've also seen a fairly high number of hemophilia A cases, most of which have been at least moderate to severe in nature, but we have had some milder forms as well that in discussion with clinical teams still feel are actionable. And so we made that decision to report even where the evidence showed that that may be associated with milder cases. We know that there will be some cases where the results are uncertain, and OTC deficiency is one example, where in one of those cases, the confirmatory biochemical testing results in that particular baby were normal. So the metabolic clinician is having to monitor and follow up that baby closely to see whether they may then start to exhibit signs of OTC deficiency. It can be very hard to tell, as I mentioned, with the variant evidence that we have, exactly when and how severe that condition will present. And that's where that long-term follow-up is really important. We found a few cases now of spinal muscular atrophy. I mentioned one of them had a really quick turnaround time, and we know that was definitely beneficial in terms of reaching that baby at a very early stage before or at early stages of any symptoms to be able to deliver gene therapy where timing really is of the essence. And RP65, again, is an exceedingly rare form of retinal dystrophy where there is a gene therapy approved in the UK that baby will now be able to have, as we were able to pick that up early before there were indicators of vision loss, although that's now clear that baby does have retinal problems. And that's a good example where potentially that gene therapy may not be available in all countries. So in countries where that treatment isn't available, is it suitable for screening in that country? And that's one of the potential reasons where we might see some variance in condition lists that we're seeing in research projects at the moment. To end on a sort of good note, this is an example of Freddie, one of the cases from the previous slide. Freddie's parents have agreed for their story to be shared with the wider media. Freddie was found to have a variant in the RB1 gene associated with hereditary retinoblastoma. There was no family history, and there was no indication at the time when we gave the result just before Freddie was 4 weeks old that he may have had any of these tumors. But he was able to then access support from the highly specialist service that we have that treats children with retinoblastoma a couple of days after we returned the results. He was found to have small tumors in both of his eyes, but the team feel very confident that earlier detection before he would have otherwise presented has been really crucial in kind of preserving Freddie's vision. It will obviously take some time for us to appreciate the real difference in outcomes and in the longer term for Freddie, but that's the initial impression that the clinical team have, and the family also feel that they've been well supported in what has been like a very turbulent, understandably, experience for them. So this is the kind of impact that we really hope that genomic newborn screening can have across a range of conditions. I'll leave just on a note of evaluation, which is to say that in running the study, our protocol is, of course, underpinned by a range of research questions and outcomes that we've tried to define with the context and the limitations that we know we have when we're dealing with individually very rare conditions. We work with an external evaluation group that is conducting a range of studies. I've put a link to their protocol on this slide, including interviews with healthcare professionals, with parents that have had a result where they're experienced consenting at different time points after their results, so we can understand what the outcomes and impact, and in the longer term, what the clinical utility and cost effectiveness might be of the cases that we identified over time in the study. And this evaluation, which will take longer than the time it takes for us to recruit the 100,000 participants, will be really important to inform future decision-making about the potential for genomics in newborn screening. So to close, I think we're finding genomics newborn screening in the generation study. It is enabling early detection of treatable conditions. We have a number of examples of that now. But it does take a whole system. It's really taken a lot of work across stakeholders around the country, the NHS, the Department of Health, our National Screening Committee, to really set us up in a way that we could be sustainable in the longer term. And there are a number of challenges, from ensuring equitable participation, a prepared workforce, and how we manage uncertain results and make sure we maintain public trust in the future. And ongoing evaluation is going to be really crucial to that. So thank you for listening. Apologies, I've maybe gone a few minutes over, but we'll be excited to hear the other speakers and hopefully time for questions at the end. Thank you very much.
Thank you very much, Amanda, for that very full presentation. We have heard very much about the generation study. I have seen that quite a lot of people have been posing questions in the question and answer, but as for now, we'll first move on to Jim Bonham, as I mentioned earlier, the president of the ISNS. Jim, over to you.
Great. Thank you very much, Martina, and thank you everyone for being in the audience. Before I start, I do just want to pay tribute to Amanda and the work of the generation study. I've had the privilege to be involved right at the beginning, offering some of that advice, and it really has been so important that that's integrated fully within our healthcare system. It's a marvelous example of how research and service delivery can work together, and I think that's just so important in all areas of medicine, but no more so perhaps than in newborn screening. Just to provide some general background, this talk is fairly general and is really to try and begin to explore the things where newborn screening is currently up to and the things that we hold so dear that have given rise to its success. Next slide, please. I think it's probably fair to say that newborn screening has been a remarkable success. First described 60 years ago and introduced in a few states in the US by Robert Guthrie, screening particularly then for phenylketonuria. And since then, it's been estimated that around 750 million babies have benefited from newborn screening, and we've identified something like 60,000 children. Putting that in context, that's a football stadium full of now adults who can lead relatively normal lives because of that life-changing intervention shortly after birth. And indeed, we estimate that around about 500,000 babies overall have benefited from that life-changing benefit of early treatment that's enabled by newborn screening. And that's led many around the world. This quote is actually from CDC in the US, but it's led many around the world to describe newborn screening as one of the major public health advances of the 20th century. In fact, I was talking to someone recently on a call, and they described newborn screening as if you want the poster boy of public health. And what he meant by that was that the uptake was so high for this public health intervention, perhaps one of the highest levels of support from the public for a public health intervention. So we have a lot to live up to, really. And today, while there's still much to achieve, we screen around about 40 million babies a year. That sounds a lot worldwide, but sadly, it leaves something like 100 million babies a year at the minute unscreened. And we're hoping that the World Health Organization framework for newborn screening, soon to be published, hopefully in March or April, which encourages newborn screening in all healthcare settings, including low and middle income countries, obviously for a very limited range of conditions in terms of biochemical newborn screening, conditions such perhaps as congenital hypothyroidism and sickle cell disease. But nevertheless, it attests to the potential success of newborn screening, that it can make such a difference even in those countries with limited availability of healthcare. Next slide, please. So where are we around the world with screening now? Well, perhaps most of you in the audience will know that it's extremely well embedded in North America, screening for 35 core conditions and 26 secondary conditions in most states in the US and in Canada. And similarly so in Australasia, where there's a uniformity of approach in Australian states now. A little bit more patchy in Europe, and we see something like 2 conditions in some countries in Europe, surprisingly as few as 2 conditions. And now actually the 61, this slide's slightly out of date, but Italy has recently increased the number of conditions to be mandated in that country to 61. So there's work to do in Europe to come to some kind of consensus about the conditions to include. The standout areas, of course, where screening should perhaps be considered and isn't, is in some regions in Africa where sickle cell disease is so prevalent, and we know that can make a huge difference. And of course, congenital hypothyroidism, early detection and treatment can be so effective and so cost effective, even in those cash limited areas. Next slide, please. Having said that, we do really still need to be very careful when we're approaching screening, and that's true for current screening and of course also for genomic screening. Why is that? Well, screening is different. We're reaching out to families who believe themselves to be well and their child to be well. And when the family agrees to screening, they're not, generally speaking, doing so in the expectation of identifying something that is wrong with their child, but rather to gain reassurance that this baby that they believe looks perfect to them is really as well as they think that the baby is. So anything that comes along to disturb that is a shock. And that shock we cannot really avoid. But of course, what we can do is to do something about those children who would benefit from that early detection and make sure that that screening pathway and program operates well. It's probably fair to say that as a public health intervention, then we would really consider the population as the patient. And it's important that, of course, we recognize that our real mission is to do more good than harm at reasonable cost. So again, when any technological intervention comes along or a new condition is to be included, then it must stand that test. Can we do more good than harm and do so at reasonable cost? But coming back to the individual and their family, and of course, that's where the rubber hits the road, and we have a duty of care to those individuals. We recognize that when offering screening, that meaningful consent really is notoriously difficult to achieve. Studies like the Generation study have benefited from being a research study and being able to take time and care so that the parents can exercise their choice. But of course, in a normal newborn screening setting, that's much more difficult to do. And indeed, many parents, while they're offered screening, certainly given information, many parents, when they eventually get a call to say that something has been identified on newborn screening, don't even remember the consent process. So we build really upon mutual trust. And that trust, as far as families are concerned, is that if we identify a condition that's on our list, we will not miss too many cases. So if we're identifying cystic fibrosis or we're attempting to identify congenital hypothyroidism, the overwhelming majority, not all by any means, but the overwhelming majority of children with those conditions will be identified by this national program. Similarly, the parents trust us that if we identify something, the journey to referral will be quick and trouble-free, and they'll get access to specialist and appropriate care in the way that indeed Amanda was talking about in the previous talk. They get access to that specialist care immediately, and that, generally speaking, will often mean within 24 hours. And that journey to see this specialist doctor will be well organized, and the confirmatory testing that's undertaken will offer a rapid turnaround time to let the family know whether or not the baby really is affected following this screening test. And finally, and perhaps most importantly, that if we do identify a condition by screening and go on to confirm it, then we'll be able to do something that really makes a significant difference to that child, and that the families will not be left with lengthy uncertainty as a result of this process due to things like variable or late onset phenotypes. These have been described as patients in waiting, where we cannot confidently say that the baby is normal, but on the other hand, we cannot confidently say that they require significant intervention, and the families are often invited to come back serially to outpatient clinics to assess the ongoing condition of the child. And that really may be inevitable for some conditions, but it's certainly by no means ideal. Next slide, please. Putting numbers to all this as far as our existing screening is concerned, two of the greatest harms of screening are probably false positive results, and we generate alongside those 500,000 babies each year who benefit from early diagnosis. We see an alarm probably around about 400,000 families unnecessarily. In general, the positive predictive value for screening for our existing conditions comes in at something like 50 to 60%, but there are some disorders, severe combined immune deficiency, where the positive predictive value may be significantly less, hovering around 10% or perhaps even in some circumstances less than that. Perhaps even more worryingly for some families are not false positive results where they can have an alarm for a period of time, but then that comes to an end, but an ongoing uncertainty, as I've mentioned, because of the uncertainty of phenotype. And that is even when we're using metabolite approaches which get us rather closer to the phenotype, perhaps, than the genomics that we've just been hearing about. So one example of that would be the condition isovaleric acidemia, where up to 80% of those identified by screening have a mild atypical form that may well never present during life, and only perhaps 20% have the classic form that requires intervention with diet and with various other supplements. How do we combat that? Well, obviously, the design of the testing, including things like second-tier testing, is really important to reduce that variability. The careful choice of conditions to include to avoid those that give rise to a variable phenotype if we possibly can. And of course, the organization and delivery of the program as a program and not simply an isolated laboratory test, to give a wraparound care, again, as we heard from the generation study, to give wraparound care from families who are having their lives interrupted in this way. But we do need to improve, and we need to protect what we have while we look forward. And the next slide, please. Into all of this, of course, comes genomics, and there are some huge opportunities, which I'm sure the audience will be well aware of. The potential, particularly, to expand our range of conditions from something like 20 to 60, as we see across Europe, to 200, perhaps even as high as 600 conditions. There's a growing range of genomic therapies that can offer almost a cure to many children with rare disorders. And it can offer help of early treatment to many, many children. And of course, very importantly for families, genomic, by extending the range of conditions, can shorten the diagnostic odyssey, the perilous diagnostic odyssey that many families with rare diseases experience. And I'm very conscious, as we're talking today, we're in Rare Diseases Week, and the huge importance for a growing number of families facing care for children with rare disorders, and a diagnostic odyssey must be almost too awful to contemplate. So anything that we can do to shorten that, of course, is welcome. Next slide, please. We do have to, though, consider, rather like metabolite-based screening, some of the difficulties and dilemmas of a genomic approach to screening. I think it's probably fair to say that interpretation of genomic variants in asymptomatic individuals is notoriously difficult. So we don't have the benefit of a clinical prior to guide us and offer some certainty, and neither do we have any family history information. We're simply looking at an asymptomatic baby. And in most studies, variants of uncertain significance are not reported. And of course, what we do know is that in some of our ethnic populations with high consanguinity, then the pathogenicity of variants can be relatively poorly characterized. And that may significantly reduce the sensitivity of detection and get down to levels perhaps of around 50% or less in some cases. And that would be new and uncharted territory for us in the land of newborn screening. And it's not just pathogenicity either. It's what effect this pathogenic variant is going to have in the individual. And of course, that's very much more difficult. The penetrance and expressivity of that is more difficult. And as those quotations that I've got on screen there attest, that in clinical and family-based cohorts, as a result of clinical presentation, the penetrance of disease can often be overestimated, compared certainly with the situation in the asymptomatic population that we'd be facing on screening. So there's a lot more to learn, and I'm sure in the context of a growing number of research studies we'll come to terms with those, but they nevertheless are risks compared perhaps with metabolite-based screening, which takes us that much closer to the phenotype in the child. Next slide, please. And indeed, this is the last slide. So what about the future? The things that we need to protect, avoid, and understand. I think top of the list there really is public confidence in existing screening. As I said at the start, there's an enormously high uptake, greater than 99% of families, pretty much right across the world, when newborn screening is offered except this intervention. And of course, that contrasts sharply with the vaccine wariness that we see in many of our countries in Europe. If anything like that happened to newborn screening, it would be a disaster. In Europe, for instance, a 10% drop from 99% to just under 90% would mean that we would miss something like 280 children each year with congenital hypothyroidism, having far-reaching consequences for them. 140 children with cystic fibrosis would be missed, 35 with PKU, and of course I could go on and on. But the point is well made that that high level of uptake, supported really by trust, we must maintain. We must also maintain a freedom for children to grow up without a label that can increase their anxiety, particularly when they've acquired that label, when they could not even give consent. The consent was given for them by their parents. And we know that some children come to resent that little in adolescence. They may then grow past that and welcome that intervention. But if it introduces increased uncertainty, we know that that can affect some children as they grow up. And then, of course, we live in a time of real political uncertainty. And what about having DNA profiles stored on all our children being born, and consequently in 10 or 20 years' time, all of our population? Do we need stronger legal protections? At the minute, law enforcement agencies in many of our countries with a suitable court order can often access newborn screening samples. And of course, perhaps if that's acceptable at the minute, but if DNA profiles are on store and our agencies can access those, is that a position that we're comfortable with? And then, of course, screening and treatment in general is around doing good, but doing so at a cost that society can manage. Now, I've put some figures on there just to guide us. I think it's good to remember that during Rare Diseases Week, there are something like 7,000 rare disorders. 5,000 of those are genetic. And if we were to estimate the average prevalence to be about 1 in 50,000, that would give us 400,000 patients a year in Europe that potentially would be identified by this kind of intervention. If genomics treatments were available for 10% of those at an average cost of €1 million, that might give us an annual bill of something like 40 billion of euro per year. And of course, that may be money well spent and cost effective in the lives of those children. But nevertheless, it's a cost that needs to be recognized and accepted by our health agencies before we can progress too far down this route. Perhaps the way to progress is taking care to optimize existing newborn screening to avoid false positives and reduce uncertainty for families. And then to progress, making sure that we have very clear case definitions to define disease, whether that's genomically or biochemically determined, and that long-term follow-up to assess and review the impact of screening is always in place before screening begins. So often we begin screening and we don't necessarily look 5-10 years down the road at what's happening to that cohort of individuals. And of course, that can teach us really important lessons. So clear case definition before screening begins, and then a commitment to long-term follow-up. We cannot just experiment with populations. We must make a sincere commitment that we will continue to monitor and support families and learn from that. By taking advantage of different approaches in combination, such as the high sensitivity offered by metabolite-based screening systems, alongside the important genomic information, we can begin to understand that more thoroughly, and that not only improves things currently, of course, but can lay important foundations for understanding genomic variants as we move into an era where genomic testing may well begin to take place in our national program. In all of this, I think by putting the public and families really at the center of our thinking, understanding what the journey of newborn screening is like for these families whose lives are touched by newborn screening, both for good and for ill, is just so important. Genomic screening offers us a new way to do this, an exciting way to do it, but of course, a way that demands that we protect what we have while we explore what we might have. Thank you very much.
Thank you for that, Jim. And in your last sentences, you mentioned the importance of the patients at the center. So that's why I now want to hand over to Gulcin Gumus, who will, from the perspective of the patients, take us through some slides.
Thank you very much, Martina, and thank you so much for the invitation. So I'm Gulcin, and I'm the Research and Policy Senior Manager with a background in molecular biology and genetics, and I'm working at EURORDIS, which is an umbrella patient organization for rare diseases in Europe, and we represent more than 1,000 patient organizations in 74 countries. So we are voicing the needs and opinions of 30 million people living with rare diseases in Europe, and we are working on patient empowerment, advocacy, and also patient partnership to bring the research forward. So today I'll try to explain how can patient organizations be a driving force in genetic newborn screening research, and how can they bring an added value and unique perspective to improve the quality of both genetic newborn screening research and the possible implementation in the future. Next slide, please. So I will talk about research and give you a specific example, and then also the wider stakeholder network, which is very important as we consider newborn screening not only as a test, but a system that includes many stakeholders in every step. So next slide. Thank you. First of all, at EURORDIS, we have a working group on newborn screening since a couple of years, where we advocate for harmonized adoption of newborn screening in Europe. So we have a multi-stakeholder group. We have 35 experts from 18 countries, so we cover a wide geographical area. And the members include clinicians, psychologists, ethicists, and of course, patient experts. So we started working together with them to bring newborn screening national programs closer together across Europe and to reduce inequalities. But our work in newborn screening is not restricted to newborn screening policy. So we also work on contributing to newborn screening research. And this is what my presentation is going to be about today. We're actively integrating our patient experts in research studies and especially in genetic newborn screening. Next slide, please. So I want to give the example of the newborn screening from Screen for Care project. It is a 5-year IMI public-private funded project on accelerating diagnosis through genetic newborn screening and artificial intelligence. And the project aims to do newborn screening for more than 18,000 newborns in different countries. And it started with the objective to do this in different panels. So newborn screening panels in treatable and actionable conditions. So it's a big project with 35 partners in 14 countries. And as EURORDIS, we're also a partner of this project. We're bringing in the patient expertise through different approaches to this research project. And I want to show you how we do it. So one of the first things that we did in this project was to develop a rare barometer survey on newborn screening with an expert committee. So the aim of the survey was to understand the perspectives, opinions, and experiences of people living with a rare disease on newborn screening. So their families, and we distributed it to our community, people living with rare diseases, their families, their carers, where we got more than 5,000 responses, and then we analyzed the results, and the results of the survey helped us to set the groundwork to the discussions to define the criteria for the choice of actionable conditions to screen newborns, to explore the feasibility of genetic newborn screening beyond treatable diseases. Another thing that we did was to develop this list of actionable conditions. So as I said, there are 2 panels to be offered, and Based on the results of the survey, discussions and consultations with different stakeholders, we defined the criteria on actionability, what makes a condition actionable beyond clinical actionability, and we prepared a gene list together with the other project partners as well, and we sent it to the ethical committees for application. Another way that we include patients was the patient advisory board, and they were included in developing materials, helping create informed consent. They also collaborated in developing the newborn screening survey, and they were also instrumental in the ethical application of the ACT panel, which we can talk about it later because the ACT panel was unfortunately not accepted by the ethical committee, but we also did issue a statement from the patient advisory board on the importance of the opportunity to explore screening for actionable conditions in a research project, in a research context, because we see that this project is an opportunity to gather the data that is needed so that we can prove the benefits of early intervention of different conditions. And there's a newborn screening form. I have a separate slide for this. So next slide, please. So Newborn Screening Forum is a unique platform that we set up specifically for the Screen for Care project, and it's led by EURORDIS, and it's a multi-stakeholder platform that ensures that the needs and perspective of the patients are taken into consideration. So in the forum, we discuss the results of the project on newborn screening activities. We talk about ethical, legal, and social implications of genetic newborn screening, and we also do face-to-face meetings. We have online meetings, and we divide into breakout groups for further discussions on the topics that are relevant to patients on the possible implementation of genetic newborn screening. Because we know that the technology is developing and we have more and more genetic newborn screening programs, research programs that are coming. So we want the patients, experts to be in these discussions. Next slide, please. Okay, so to give you an example of what we discussed the challenges for implementation. We discussed mainly the importance of transparency, consent, giving proper information, acceptability, the importance of scalability, and the importance of data sharing, safety of collected data through genetic newborn screening. Next slide. We also talk about, we also talk about best practices, the importance of sharing best practices, and also importance of building the care pathway once the newborn is diagnosed, and follow up, working together with ERNs to maximize the benefits of genetic newborn screening. We talked about the importance of public perception of genetics, genomic literacy, and also training of professionals as well. So not only the public, but also training of professionals, scalability of genetic newborn screening research programs to the public healthcare system. Next slide, please. So we have gathered, summarizing all these discussions that we had, a report on considerations for patient-focused advocacy on genetic newborn screening, where we talk about different considerations from ethical, social, and economical perspective when it comes to the stage of implementation. So it's a 3-page report that summarizes the discussions. We talk about topics like informed consent and how long-term storage and secondary use of genetic data requires transparent policies and respect for family privacy as well. We talk about genetic counseling and how it should be accessible and it should be recognized as a profession so that we can give the support that the family needs and the resources that the family needs. We also talk about screening criteria that should be based on agreed standards to make sure that we have equitable access, and we also need to focus on conditions where early diagnosis benefits the child and the family. So I think the patient organization as partners in this type of project is very important. And at Screen for Care, we did ensure to contribute through the newborn screening forum, through our focus groups, through different meetings, not only as EURORDIS, but including also different type of patient organizations in that as well. And we have been leading the task, we have been taking active roles, and we have been discussing the topics that matters to the patient community, ensuring that the project is patient-centered. So what we have to, as the patient organizations in these conversations, to start asking the questions that the other stakeholders might not ask if they're working in academia or in technology development or regulatory fields. So this is where we bring our added value. Next slide, please. So with the networks and dissemination, we are very happy to be involved in many societies and networks and to not only distribute our work, but also to be able to discuss with different stakeholders, to bring our perspectives and have these discussions. We're working together in different global and European networks, being involved in different task forces, producing scientific papers and presenting them to the public, and joining the workshops to debates and disseminate the results of our work, and also making sure that the patient voice is there. So we are defining areas on collaboration with European reference networks, as well as they are also not only key for diagnosis, but also on patient referral and treatment pathways after diagnosis. So the next slide. We really need to work on how to work better, because we're not only talking about engaging patients anymore, we're talking about patient partnership now. So we're talking about the process of actually creating together, discussing together, and bringing in the patient expertise as valuable partners in research. And for this, dialogue between patients, parents, policymakers, and researchers is very, very important. And yeah, there is a lot of ways for people living with rare disease to be included in the genetic newborn screening research, as the examples I gave you. And also we have to keep in mind the impact of early diagnosis that can be life-changing for patients. So as a last slide, I just want to talk about our upcoming conference, which will take place in June, ECRD. It will bring different stakeholders with parallel tracks, and one of them is on diagnosis and newborn screening and research and prevention. So we will have 2 different sessions on early detection, newborn screening, and the journey from rare disease diagnosis to treatment. And this is also another example of how people living with rare diseases can actively bring their perspective into discussions with different stakeholders. I encourage you to sign up, take a look. And if you want to know more of our work and how can you be included as a researcher and include patient voice in your work, you should check out EURORDIS website for the projects, guidelines that we have prepared, all the past surveys that we have on newborn screening and also diagnosis. And you can join our ECRD session or reach out to me directly. I'd be very happy to have a conversation with you. And thank you very much.
Hey, thank you very much, Gulcin, and also thank you very much, Amanda Pichini and James Bonham. Fortunately, many of the questions that had been typed in the Q&A have been answered already, so thank you for that very much, Amanda. And in view of the time also, I think we have to close now shortly. Apart from the conference that Gulcin was already mentioning, there will also be a European Society of Human Genetics meeting in June, and there will be a session also on genomics newborn screening, a debate session, so hopefully all of you will be there as well. And then there will be another webinar, episode 3, in March, where Lidi Milani will speak on pharmacogenomics. And finally, there will be a special issue of the Journal of the European Journal of Human Genetics. The deadline, unfortunately, has already closed, but something like 30 papers are expected to be published there on this very intriguing topic. So hopefully you all will read that special issue and come to the June meetings and there keep on discussing this very interesting topic. Thank you very much for your attention.